welcome to the PODDocs. I'm Dr. Damien Dauphinee, and I'm here with my partner,
Dr. Raafae Hussain.
And we are going to discuss pediatric flatfoot today. And Dr. Hussain, what do you have for us here?
So pediatric flatfoot, I think, is probably one of the more common things that we see in kids. Ingrowns and flatfoot deformities, I think, are probably my two highest things that I see with children. Typically, the parents will bring them in, talk about that they're having, aches and pains, that the kid is running around, little Timmy's running around, but he's not able to keep up with his sister. And he sits down, he rubs his feet. He's like, I'm tired, my feet hurt, blah, blah, blah.
Sometimes they're tripping, they're having other
struggling.
issues.
Yeah. Sometimes you'll hear that slappage gait, that little slapping of the feet whenever they're running rather than, nice healthy gait. And they'll see, obviously, the flattening of the arches. Now, arch collapse or arch flattening is common in younger children, depending on, the internal and external rotation of the tibia, and that kind of does play a part, but the general collapse of the arch is something that we do want to avoid.
So for some kids, they're going to grow out of it.
Yeah.
You give it some time, tibial torsion kicks in, their hips move into the appropriate anatomic position, and you don't see it as dramatically, but then there are those that clearly it's going to be an issue for them later on.
Yeah, and patients will ask, is he going to grow out of this? Is this something that he's going to have to deal with? His father has flat feet. Is this something that we should be aware of? And I'll be like, look, we'd like to treat it conservatively initially, and if we see that, by the age of 10, 12, 11, whatever, like once they hit puberty and the growth plates start closing, and if the foot hasn't changed, then by all means we can start talking about more aggressive therapies. So what are we seeing clinically? We'll do our exam. Something that some people point out, Dad will be like, when he's sitting there, he's got great arches, but when he steps down, his arch collapses, and that's because he has a classic pediatric flexible flat foot. Mm-hmm. The joints are still healthy. There isn't any arthritis holding the joints up anymore. They're kids. They're super flexible, but when they step down, their arch is going to collapse. And this is a little test that we do. It's called the Hupshire maneuver, where we take the big toe joint and we literally elicit what's called the windlass mechanism. And we're pulling up on the big toe joint, flexing that toe up, and you can see the bands pull, the flexor hallucis longus pull, and it recreates that arch. And so we know that the arch is recreatable, it's flexible. You'll see that when they're sitting, arch is nice and high, but when they step down, it's flat. We'll have them do toe raises. Toe raises show us that the heel is turning in, the posterior tibial tendon and the Achilles tendon are firing and supinating the foot, so we know that, everything's working fine. When things aren't working fine, then we look at, other problems that might be going on. So when we're looking at it clinically, this is probably one of the most common things you see, right? That heel turning out, the ankle collapsing in. Mama's like, when he steps down, it looks like his ankles are just like flexing in so much. So what we're looking at here is literally the calcaneus, the heel bone, turning out, physically rotating out in the frontal plane, out from underneath the tibia and the talus. The natural collapse, we would like to say between 0 and 8 degrees of pronation, but obviously this is far worse than that.
Yeah, we need that for shock absorption. That's an important part of absorbing shock during gait, but when you get beyond that, then you start putting those joints in a bad position.
Yeah. Other things that we're looking at is when you're looking at them from behind, you can see the too many toe signs. A simple clinical exam, clinical whatever finding that we see, and Mom probably catches this easy too. He's walking, and it seems like his toes are walking outwards, He's walking like a duck. He's waddling, whatever you want to call it. What we're seeing, it's a simple thing. That foot's collapsing, that pronation, the abduction of that forefoot, and the too many toe signs. You're literally walking an out toe. And they do that because they're trying to avoid joints that aren't flexing the way they should. So they're walking outwards to help remove the stresses on those joints. So you're flexing off the inside of your foot. And I'm sure you see this too. I mean, as they get older, they get those calluses on the inside of their foot, the big toe joint, the IPJ of the hallux, the posterior tibial tendonitis.
Right.
They end up getting that pull along that posterior tibial tendon, and it gets worse. And we talked about that one of our other lectures. But yeah, very, very common sign to see. And then generically, your arch collapse. You're the most obvious factor. The arch is literally pancake flat.
Right.
Imaging. So we do our physical exam, we do our range of motion exam, and we determine, there's a flat foot problem going on. let's see what it's looking like on the inside, because there are things that you can mix. If it's too rigid, here's a prime example of what a navicular cuneiform
coalition
looks like. Yeah. I mean, not so common. I mean, how many do you see a year of these?
It's pretty rare.
Yeah. I mean, handful. I mean, I'm literally talking like single digits.
Right.
And, very simple, very obvious. Sometimes when the bones haven't, ossified like here, we won't see them as great. And that's when we talk about getting your MRIs, your CT scans to see if it's still fibrous or cartilaginous. Here, vertical talus, this is something that is a congenital problem. The talus is literally subluxed under the navicular. And this is something that I don't personally even treat. I literally send it off to...
we usually don't even diagnose these. They're usually caught pretty early on and sent to Children's or Scottish Rite.
Yeah, it's something that you want to aggressively treat surgically and conservatively. They typically do like serial castings and surgical intervention, and they do heal up well. I mean, there's patients that you wouldn't even realize that they had vertical talus. And then your classic, your flat foot deformity. This is a non-weight bearing X-ray, so it's not the best. But here you can kind of see what we're looking at. Some of the bones haven't even ossified yet. Some of the different growth plates haven't ossified yet. So here, younger child, probably like 3, 4, 5. And here, this is probably preteen. You can kind of see some of the growth plates are starting to close. Some of them are starting to ossify. But yeah, we can watch those bones pretty much grow in. It's amazing. So what we're looking at, me and Dr. D, when we're looking at these kids, they come in, and the x-rays, the arch is collapsed. What measurements are we specifically looking at? So on the lateral x-ray, I look at 2 main measurements, your calcaneal inclination angle and your first metatarsal talar angle, or Meary's line. So calcaneal inclination, I'm looking close to 20 degrees. We have little measuring apps on all our x-ray machines, and we want that close to 20. Here it says 18, plus or minus a few degrees, no big change there. And then obviously your talar first metatarsal angle, you want that, dead straight parallel.
Right. And when you see that acute change, that faulting in the midfoot.
Yeah, it'll break down right here.
Right.
You want that line to come out straight out that first metatarsal head. So here's a good example of what a flat foot looks like.
Right.
So here, the calcaneal inclination angle is
diminished.
Yeah, it's pretty much
probably
flat.
6 or 7 degrees maybe.
Next to nothing.
And you've got your calcaneus and your talus literally sitting next to each other.
Yeah, that's that overlap. That's that pronation. That's that hind foot turning out. So when we're getting that lateral x-ray, they're overlapping one another. That talus should be sitting on top, like here. It should be sitting right up on top, proud. So the other thing we're looking at is obviously that talar first metatarsal angle. A simple thing that a lot of people miss is that first metatarsal base doesn't come all the way back here. That's your second metatarsal base. Your first metatarsal base is this one right here, with the little growth plate right there and coming up proud right here. That's pretty much parallel to the ground.
Right.
So that fault is right there in that midfoot. Other views we're getting, top view, your AP view or DP view, wherever appropriate terminology is now. Same thing, your first talar angle should be parallel, just like your lateral view. And then the other thing I'm looking at is your CC joint, your calcaneocuboid joint. These should be parallel also. A lot of times you'll see that foot abduct on that hind foot, and that angle gets larger and larger and larger. And the last thing, something that is easily missed, is your meta-abductus angle. A lot of times when you have your skew foot or Z foot or whatever new names they call them, that meta-abductus angle is something that you have to pay attention to, because they'll be like, oh look, it looks like he has a straight foot, but his arch is collapsing. But then we'll get the imaging, and that meta-abductus angle is
extreme.
Extreme, yeah, because that hind foot will be oblique, will be laterally deviated. Your midfoot will be the opposite direction. Oh, sorry. Your hind foot will be, medially deviated. Yeah. Your midfoot will be laterally deviated, and then your forefoot will be medially deviated. So you get that little skew effect, and it'll falsely look like they have a normal foot structure, even though their arch is collapsed. But they'll have that skew foot, and that's a little bit more of an aggressive surgery to fix. So here, I think I have some x-rays of that here.
Yeah, there's a classic skew foot there.
Oh, yeah. Look at that. That hind foot.
It's going one direction, midfoot's going the opposite direction, forefoot's going back.
Yeah. So if you drew a line coming up that talus, I mean, that's coming out right here.
Yeah.
And you're like, oh, look, looks fine. But I mean, if you look at the rest of the foot, your CC joint is abducted. Your forefoot abduction, that's your metaductus. If they didn't have that hindfoot problem, this person would be in-toe walking. But since they're not in-toe walking, it's easily missed. Here's a classic flat foot deformity right here. Your CC joint, your talar head uncovering, that's literally subluxing out of that joint. It's stretching the posterior tibia tendon and that spring ligament structure. Oh, this is totally forgot this wasn't even in here. Your hind foot. This is great. This is showing that how much pronation or valgus effect of your heel bone you can see on that X-ray. It's literally
that's extreme.
Yeah, it's turning out, and we, like I said, we want that closer to 0 to 8 degrees. Some people, different measurements or whatever. But the valgus effect of that heel, that's that pull arm of that Achilles, and we're going to dive into that a little bit. But if you imagine if the heel bone is being pulled up by the Achilles, that Achilles is going to do more pronation than supination, and you really want that to be closer to neutral to supination.
And you can see that blue line is running through the center aspect of the tibia and coming way medial on the heel. So just their own body weight, gravity pulling on them, is going to cause pronation.
Yeah.
And worsen the deformity over time.
Yeah, it's like what is it called? Those seesaws,
Mm-hmm.
If you shift that apex or that it's teetering, that plays a huge factor. So that's that apex. This is the lever arm. We're pushing a little bit of force here. That's naturally going to collapse. That's why when we do our surgeries, we'll try to shift that back over, and we'll go through some procedures we do to do that. Conservative measures. So typically we'll start off with some conservative measures. Simple things, orthotics, no brainer. You classically use like the UCBL type. I'm guessing you do the same, right?
Yeah, usually the over-the-counter prefab version, because they're growing out of these so fast.
Yeah, they're just gonna run through them. I mean, a few months, 6 months, and their shoe size. If you're a parent, you're buying shoes like every few months.
Right. This is great, showing the change in the calcaneal line from outside the orthotic to using the orthotic. It really lines it up nicely.
Yeah, it's a simple thing that, it's an insurance policy. You're like, look, if we can strengthen that arch, we can strengthen those tendons, make sure those tendons don't get weaker, hold that in neutral, maybe we can avoid surgery in the future. Maybe his foot will grow out of it. If
you're realigning the joints and allowing them to continue to develop in a better position.
Yeah.
So I think it makes a lot of sense.
Your classic UCBLs are a little bit more aggressive than your typical orthotics. They have a deep heel cup to hold that heel in neutral, so that your classic orthotics are pretty shallow. These ones are very deep heel cup. They have a medial and lateral flange to help hold that foot from abducting, and they're obviously going to have an aggressive arch in there to help bolster that medial arch up.
So those would typically work better, but they're expensive to manufacture, and if you have to have them done every 6 months, that can get cost prohibitive.
Yeah. If insurance covers it, custom is definitely the way to go.
Right.
Typically, insurances don't cover it like that.
Yeah.
They'll cover maybe one a year if you have great insurance.
Or one per lifetime.
Oh, yeah. And it's silly. And it's like, hey, right, I can try to treat this conservatively. It's going to cost you much less. Or we can do surgery, which is going to cost you a ton more. But that's not what insurance thinks. But yeah, simple, effective. Physical therapy. This is something that it can work if you are aggressive enough in certain patients. It's not going to work in all patients, but they're strengthening the tendons, they're strengthening the foot muscles, the intrinsic muscles. These are some exercises that actually have some patients do when they have like plantar fasciitis. The simple pulling the towel. It's a simple exercise. You're literally scrunching that towel up. You're working those intrinsic muscles, so it can help support the arch. Little arch builder exercises. She's eliciting that windlass mechanism. It's simple things. They're not very complicated. Your physical therapist will go through them. So if all that fails, now we're talking about going in surgically. This is probably the most common procedure I do in flat foot deformities. It's called a subtalar arthroresis. We're going in and we're changing the pitch angle of the subtalar joint to allow it to prevent that external or over pronatory effect. Very simple.
Just
honestly,
blocking motion.
Yeah, it's literally blocking motion.
Right.
That's such a good way of explaining that. You go in, we're putting a small implant in here, and it's gonna physically hold it. It's like I don't know.
The best way to describe it is it's blocking that pronatory motion, so it's keeping the talus from declinating or dropping into that pathologic position.
Yeah.
Yeah.
Simple, effective, small.
And it's doing it
small
extra
incision.
articularly, so it's doing it outside the joint. It's not destroying the joint.
Yeah.
If it doesn't work, you can take them out.
Yeah. Sometimes patients, they'll have them for lifetime. Sometimes patients will have them for like 5-10 years, and they're like, all right, I can kind of feel the aches and pains of it. And it's safe to remove now, and we'll remove them because now the joints have healed up around them that they don't necessarily need it anymore. Here's a prime example. I think if I remember correctly, this patient had a gastroc recession and a subtalar arthroresis.
That's
simple,
beautiful. Yeah.
simple, effective. Here's the before. Here's the after. It's a no-brainer type of surgery, and this is something I will do on younger patients. I'll do the gastroc and I'll do the subtalar arthroresis, and maybe a calc slide if they need it or not. But it's very minimally invasive, and it helps. It's like your internal orthotic. It works beautifully. Calc slide. So we just talked about calc slides. Calc slide is when we take that heel bone and we slide it over medially. So remember those x-rays we were looking at before where the heel bone is turned out and it's not under the tibia and the talus anymore? So calc slide is you're physically sliding it over. You can do a wedge also. I typically do the slides. So we're literally physically sliding that heel bone over underneath that tibia again. Very effective. We're taking that pronatory effect of that Achilles when it's pulling, right? When the Achilles is going to pull, it's going to pull that foot flatter when you have a pronatory or your classic flat foot deformity. And then when we slide it over, now we're shifting close to that midline and maybe just a little bit more. And so it's more of a supinatory effect. The only trick with calc slides in children are that you don't want to violate that growth plate. So classically, when we do them in adults, we'll use the 2-screw method. The 2 screws coming out the back of the heel, sometimes 1 screw. I typically do 2 screws. But in children, they have a growth plate there. So if we're doing them in younger children and the growth plate hasn't completely solidified, you can do these fancy plates and stuff, or you can use smooth K-wires. Back in the day, that's what we used. They didn't have all these snazzy plates, step-off plates and whatnot. I'm sure they used K-wires also when you were training.
Yeah, we had a few plate systems that were coming online. They weren't locking plate systems, but they were similar to this with the step-off.
Yeah. And the purpose being to avoid that growth plate, right? Because they're going to continue to grow. You don't want to hinder their growth. You don't want one foot shorter than the other.
And some of these are really nice. They've got a lag screw component to them. Yeah.
And you can see this one got the subtalar arthroresis and the calc slide. Gastroc recession. That's what I do typically. Achilles lengthening. So Achilles, the tendon, not the action hero, but the Achilles tendon can be short and pulling on that heel bone. So if you can imagine, if you have a short Achilles tendon and their foot is in that equinus or your 4-foot down position, so when it's going to hit that ground, it's going to want to collapse because that Achilles isn't allowing that motion that it needs. So it's literally forcing that midfoot up and that 4-foot up. And what we're trying to do is avoid that excessive force.
Trying to take that out of the equation.
Yeah. So here's what it will look like when the Achilles is pulling up. It's literally causing that hind foot to lever that midfoot flexion. So typically, there's 3 main ways that I typically will lengthen in children. The Achilles, most commonly, your gastroc or your striator stripping. It's that partial resection. We determine if it's the gastrocnemius portion or the soleus gastrocnemius portion of the Achilles tendon, and most commonly it's the gastrocnemius portion, and we'll lengthen it. Very simple. I do these typically arthroscopically. You can even do them open. And the kids, they'll heal up. Scars are, you barely ever see scars in children.
Right. Minimal.
And if it's the both bands that make up the Achilles, the soleus and the gastrocnemius portion of the muscle belly, then I'll do your Z lengthening or your hook. More commonly, I'll do the hook and watch that fill in. Z lengthening on like more aggressive lengthenings, like your cerebral palsy type of equinus type of patients. But yeah, simple, effective. Probably I do them almost 99% of the time. Kidner. So a Kidner procedure is where you take the posterior tibial tendon, the main tendon that helps supinate that arch and bring that arch nice and high. You take that tendon, you take out any ossicles or bony deformities that are injuring that tendon, and you move it more plantarly and deeper into that foot. So if it was attached here, I would take that and I would slip it in deeper and attach that to here. A good maybe, I don't know, centimeter and a half, lower and deeper to help bolster that effect.
And you're remodeling the navicular.
Yeah. So you really can't see here because this thing is in the way, but here you would see, let's see if I can find a different picture. Top of the foot, x-rays. So there's not a good example. Well, what you would see is a gorilloid navicular or an accessory bone that would be sitting on the inside of that foot.
It just makes it real prominent. Yeah. You can see it right there. There's still a little bit of it left.
Yeah, I gotta figure out a way to move this thing. Too snazzy for me. But yeah, what we're literally doing is realigning that tendon so it pulls harder. You take the accessory bones out so that tendon doesn't get injured continually, and you're remodeling that inside so you can allow that foot to have.
How often are you doing that procedure by itself?
Oh, never.
Yeah, I was going to say it's pretty rare that we would do that by itself.
So, general rule of thumb, all you young docs out there, soft tissue procedures and flat foot deformities, you're fighting an uphill battle. You got whatever 100 pounds of weight, young child, 80 pounds of weight, young child, whatever it might be, coming down on a specific tendon. You can't expect that tendon to especially a tendon like that, to hold that arch up. There's too much fighting against it. You got to do your additional procedures behind him. Typically,
maybe an Evans.
Yeah, calc slide, Evans, arthroresis, gastroc, whatever. I mean, there's a whole shebang of things you can do to help make sure that your kidney procedure is successful. Even with my adults, I mean, I've never done this alone. I don't think anyone does them alone. Evans, perfect.
There you go. Segue.
So your Evans procedure is where you do a lateral column lengthening procedure. It is extra-articular, so the joints are still fine. In certain adults, we'll do them intra-articular because the joint is so shot. But more often than not, we're doing extra-articular. You're doing an opening base wedge osteotomy here, and you're literally flexing that lateral forefoot over towards that medial side again.
Yeah, you're lengthening it to realign. Yeah.
So here's the typical pre-op. You're seeing that talar head uncovering. You're seeing that CC joint. And then post-op, you see that CC joint is nice and straight. That talus is perfectly covered.
I think the thing that's so amazing about that procedure now is that we're really going towards these metallic implants.
Yes.
And away from cadaveric bone, which is such a paradigm shift. You just can't imagine that you stick that hunk of metal in the foot and it's going to grow bone through it and around it and over it. And it does. It's amazing. Yeah,
the way they make these, I mean, either they'll look like a mesh or they'll have like a hollow center. Some of them, I mean, certain ones are made out of PEEK and titanium and whatever. But the general purpose being is that it's open. So typically when I do these, I'll put like bone putty or something in there, bone chips and stuff in there, depending on what's available to me. And it'll act as a scaffold for that bone to come grow across. And then, I mean, honestly, it's pretty much part of your bone after that. You'll never even notice it's there. Sometimes we'll use like a little staple or a plate or something to make sure it doesn't flex out, but most of the time...
We used to do that to protect the the cadaveric bone, for sure, because that could crush down, but with the metal implants, the 3D printed implants, you don't even need to do that.
Yeah, honestly, it's like a force fit, friction fit. Oh, call this Evans. It's supposed to be a cotton wedge. Correction.
Yeah. The cotton to bring the medial column down.
Yeah, so there's most common way is a opening wedge where we literally are flexing that forefoot downwards. In this patient I'm doing that skew foot deformity, and we're doing a modified lapidus, but we're doing that opening wedge style. Literally bring that forefoot down and over, but the purpose being to bring that forefoot down to the ground again. Some people will do a closing wedge on the bottom, depending on the type of foot structure. Some people will say, I read a paper that they'll take that wedge from here and they'll put it on the...
Flip it around.
Yeah, on the Evans wedge side. They'll take the cotton wedge and they'll use that as a graft for the Evans wedge. I mean, there's tons of ways of doing this, but the purpose being literally recreating that arch. You see that you bring that foot over, right? Sometimes you'll do the arthroresis and that forefoot will be sitting up. You're like, all right, I got to bring that back down. So now we do that wedge and bring that forefoot back down. Simple, real straightforward. And these are another ones that, you're using those fancy implants now that we don't have to use any of those bone wedges anymore. Recovery is the same. Children are pretty quick on healing. Adults, I would say 6 to 8 weeks non-weight bearing. Children, I typically do 4 to 6 weeks non-weight bearing. And the bone is healing beautifully in kids. They heal up so fast. They'll be walking in that boot short time after that for about 4 weeks roughly, and then back to normal shoes. I do typically recommend that they do orthotics after that regardless.
Right.
It's a simple insurance policy to make sure that arch stays nice and supported, doesn't become angry with them. And you can slip them from shoe to shoe. It's not like you're wearing this giant brace. So it's a simple thing that they can do. But yeah, that's it as far as pediatric flat foot deformities.
Excellent. That's a great before and after.
Yeah.
So I think it's important to note that not everybody grows out of this.
Yes.
That it is okay to watch it until they're preteen.
Yeah.
Age-wise. You can prevent really a world of hurt as an adult if you address it early.
Yes, definitely.
I think that the severe cases, and occasionally you'll run into somebody who had pediatric flat foot clearly and now has an adult rigid flat foot.
Yeah.
And they do okay, but they're usually sedentary. They don't have a job that requires them to do a lot of walking, so they're fortunate. But
their lifestyle changes.
Right. Yeah. And they may have made those choices because of their feet, not even realizing it. But it's certainly something that we can intervene early and actually have a really positive impact for the patient for the rest of their lives. Awesome. Very good. Thanks, Dr. Hussain. That was an awesome overview of pediatric flat foot. So what do we got coming up? We're going to do another episode on bunions. Yes. On deciding which bunion surgery to do of the 14 that are out there for each individual patient. So we'll talk about that next time. So we'll see you next time on the Pod Doctors. Thank you.